Hi everybody, great to connect with you again. I said I would put a quick functional checklist together for you. So here it is in some simple steps, and I hope that this helps you do better dentistry. First of all, I'm looking for bilateral simultaneous contacts. What do I mean by that? Well, when we put some carbon paper into somebody's mouth and we ask them to tap their teeth together, and I like this product here, Troll Foil, which is a carbonated shim stock about 8 microns thick. We ask the patient to tap, 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 and we're looking for uniform contacts all the way around the arch. So when we see a little point that's a bit heavy, a bit darker, a bit bigger, we know that there's premature contact at that point. It's tempting to want to remove it completely, but I like to just make a small adjustment so that I've still got contact at that point. Be careful that we don't remove that contact completely, otherwise we're going to get over eruption of an opposing tooth potentially and create an interference subsequently. So you want to have evenly distributed dots of a similar intensity and colour. The second thing I'm looking for is no chewing interferences. What do I mean by that? Well, Lundeen, Schrock and Gibbs in this classical study described the normal envelope of function. They referred to the border movements of the mandible, and that was described very well by Posselt, but they said that day to day we function in a much narrower zone. So you can see it here on the diagram as the bright green zone. When we put our heads back and we're in a supine position, which is typically where we check the bite, we find that the zone is much narrower, and you can try this by tipping your head back and trying to simulate chewing. So typically I would sit the patient up or put them at about 45 degrees to check the occlusion more accurately, because then I'm going to record the complete range of movement. Remember that functional movements are things like speaking, eating and swallowing. And my great mentor, Dr. John Coyce, who runs the Coyce Center in Seattle, talks about us functioning from outside in. One of the things that I was taught at dental school after I'd done the tap, tap, tap thing was to say to the patient, grind your teeth from side to side. And that's a very guided pathway. That's an inside-out movement. But Dr. Coyce says that we actually operate in the reverse. So if you think about it, when we go to put food in our mouths, we open our mouths first of all, and then we close up and we make functional pathways. And the teeth will momentarily come into contact and then we'll open again. So that's the kind of movement that we want to record and check when we put any kind of restoration in somebody's mouth. So how do I do that? Well, I use a different coloured piece of carbon paper. I like to use Miller forceps. I find these are really helpful just to keep the cheek out of the way. And so I tend to use blue for checking MIP, maximum intercuspation position, or the best fit of the bite, where we ask the patient to go tap, tap, tap. And then I like a red articulating paper to check functional movements. So when we do those checks, let's say we've cemented a crown on the lower right first molar, the 4-6, you can see here that the patient's gone tap, tap, tap with the new crown, and then we've asked them to chew. And we might find that we get a big red streak up on the incline of the lingual cusp, the distolingual cusp. And I don't want to see that there. That means that the technician's created a few microns of extra volume in my new crown that's potentially going to cause an interference and subsequently pain. So the patient might come back a few days later complaining of sensitivity to pressure and also to cold. And we put our carbon paper in and we go tap, 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 and everything looks great. But what we may not be picking up is that functional interference. So it's a really important step whenever we put any kind of restoration in a mouth. Here's a provisional restoration that I've put on an upper second premolar, and I'll show you the adjustments that I go through in this short video. You'll see first of all that I'm checking just our centric occlusion contacts, or MIP, with blue paper, and then we'll go to the red paper. So let's take a look at that process. Here we are asking our patient to tap, tap, tap their teeth together. I'm using Troll Foil in this circumstance, and I'm looking for any contacts that are a little bit heavier. And on my provisional, I've got a slightly heavier blue contact. Sometimes that's just the film thickness of the provisional cement. So I'm going to take that down a few microns. I've also picked up a bit of a slide on the molar, so you can see that there's a streak of blue, and I would prefer that that was actually a point contact. So I'm going to make a small adjustment and remove part of that streak on the incline. I want the contact to largely be on the occlusal surface. So I'm just going to pare that back so we take it back to a point contact. The marginal ridge also has a contact on an existing restoration, so I'm going to just bring that contact in. I really don't want a heavy contact right out on the marginal ridge. So tiny adjustments that I'm making there to either my provisional, and if I pick up something on existing restorations, I'll do the same. We're then going to ask the patient to chew. So here I've taken some red carbon, patient's going through a simulated chewing movement, and now we're looking for red streaks. I'm going to go back in a second and put the blue paper in just to double check and see that we've got overlapping marks, but where we don't, where we have a red streak coming off the overlapping colour contacts, then I want to get rid of it. In this case, we've got a marginal ridge streak of red on the provisional and just a little bit coming off the occlusal contact on the provisional. Let's double check that with contacts and MIP. Great. And let's go back and have another look, and we can see very clearly where those interferences are. And I'm going to go in and just adjust those very lightly and keep repeating that process until I've got superimposed colours of red and blue and no significant red streaks coming off those blue contact points. The other thing that I want to do, and this is particularly important when I'm doing anterior restoration, so this is my third functional check, is I don't want any speech or phonetic interferences. So when a patient counts from 60 to 70 out loud, we'll often pick up interferences perhaps on the palatal surfaces or even the incisal edges of anterior teeth when we've done restorations. Here's a patient who's come to me having had orthodontics done and teeth aligned and an implant placed in a lateral incisor position. Unfortunately, he's got very proclined anterior teeth and a very much an edge-to-edge relationship. He's wanting me to enhance his smile with some aesthetic dentistry in the upper arch, and I want to lengthen some teeth and certainly get the incisors the same length. You can see that the temporary restoration somebody put on the implant has fractured, and that's probably because there were functional interferences going on. So if I want to lengthen these teeth, I'm going to have to bring them forward, have a very flat interincisal angle, and I'm going to take some video footage just to see what happens when he counts from 60 to 70 with a mock-up in the mouth. You'll see straight away the interferences that are occurring. So he counts, I ask him to count from 60 to 70 out loud. So that's what he's doing here. And when we take a look in the mouth, we can see very heavy contacts on the incisors, a light contact on the canine, and I would prefer to have lighter contacts on my anteriors, heavier contacts on posterior teeth. Heavy contact on incisors and a very proclined tooth with a flat interincisal angle. So the only way that I can bring these teeth in, and we'll also find similar kinds of interferences when he goes through a chewing pathway. You can see I've got him chewing gum here. Let's take a closer look at those interferences and functional markings on his anterior teeth. The only way that I can bring those teeth in and create longer teeth is to open the vertical dimension in this case and create a little bit more space. So if you're seeing these kinds of markings on your newly placed anterior restorations, they will need to be adjusted. It might mean that you have to adjust the lower incisors and with the patient's permission take a little bit of enamel down on the incisal edge or the facial surfaces of those teeth. Here's another interesting case, patient who's had some veneers done when she was about 21 and has been suffering from quite a lot of discomfort, chewing discomfort, headaches, a feeling like she wants to clench. And I don't think it was necessarily the veneers that were the problem, although we can look at some of the posterior veneers on the premolars and see big red streaks across the occlusobuccal inclines. We've obviously got interferences anteriorly, so when she's chewing, she's getting big red streaks on her incisors, and if we look at the lowers, we can see the heavy contacts anteriorly, once again, red interference streaks on those teeth. So I'm going to go in and do a bit of an equilibration, which might mean lowering the incisors down, the lower incisors, and maybe doing minor adjustments to the palatal enamel on the upper incisors. And I think what's happened with this patient is that she's grown a little bit between 21 and where she is now at 27. But she's been suffering quite a lot of discomfort all of that time. If you look closely on an upper second molar, there's also a huge interference on that cusp. So we might find also that there are posterior interferences driving her forward. And I'm going to do a sort of wholesale equilibration for this patient to try and get her more comfortable. The fourth check I do is F sounds. So any time that we do any anterior dentistry and we're lengthening teeth, we need to get the patient to count from 40 to 50 out loud. If the patient's making a very kind of sound, a 40, 50, and we see that the restoration is embedding in the wet portion, the wet-dry zone of the lower lip, they will be very conscious of their speech and the teeth will need to be shortened. So here I've got a provisional that's just a little bit too long. Once we've done the final veneers on the anterior teeth, we've adjusted the length back, and the patient can now speak cleanly and clearly without feeling like she has a functional interference. Sometimes with cases of extreme wear where we want to lengthen teeth, and in this case we've got a patient who doesn't show any tooth structure in repose, and you can see the concave and very worn smile line that she has. Here's the occlusal view of the wear patterns that we've got. And I can draw on some lines, a smile line that would indicate an optimal form for her face and her smile. But you can see we've got quite a discrepancy in length between those worn teeth. Another dentist has tried hard to improve her smile by bonding some composite resin to the teeth, but within a few days of doing that, those composite resin veneers broke. So in this circumstance, we can anticipate, based on the correct tooth proportions, the ideal length of the tooth. I'm going to have to open the vertical dimension, and we'll do that by deprogramming her, creating a digital smile design of optimal tooth lengths and proportions, going to a diagnostic wax up on the lowers, and creating a transitional composite resin overlay. Here are the uppers as we've waxed up with optimal proportions, and we've created a transitional overlay here in composite. You're seeing it now before I've trimmed away any of the flash. And if the patient were to close together, we'd suddenly have an anterior open bite and some room to move in terms of lengthening teeth. I did that in the same appointment, but I didn't check the functional F sounds at that point because the patient's going to have a few days to get used to that new vertical, try out a new bite and the new length of her teeth. And we will find that her freeway space reestablishes, her vertical changes, and suddenly the dynamic between her soft tissues and the length of the incisors might change. So any time that I'm doing any kind of opening of the vertical dimension in conjunction with anterior lengthening of teeth, I won't make that definitive determination of tooth length for a few days until I've seen the patient test driving the new bite. And here you can see that I actually did design something that was a little bit flat. We had scope, ultimately, once she'd gotten used to the new bite, to lengthen the teeth a little bit more. So any time you open the vertical dimension and you want to lengthen anterior teeth, go back and double check that 40 to 50 process where you get the patient to count out loud and listen for that clean, clear sound. So these are 4 simple little checks. I hope they've been a huge help to you in your practice. Enjoy your dentistry, and if you want to get in touch and know more about some of the programs that I'm running, you can contact me at this email address or connect with me on LinkedIn.